Hi, everyone. My name is Einat. I'm Shira's mom, and I'm the founder of Shield for Life, a nonprofit organization dedicated to changing the fate of children with neuroblastoma. In the neuroblastoma journey, surgery is more than just a step in the treatment plan. It's a true turning point, both medically and emotionally. From a clinical perspective, surgery plays a vital role, no matter the stage at which your child has been diagnosed. The goal is to remove as much of the tumor as possible, but neuroblastoma is rarely straightforward. Tumors often wrapped around major blood vessels, organs, and nerves, making each operation uniquely challenging. That's why experienced surgeons are so crucial. They study every scan, plan the surgery carefully, and make split-second decisions in the operating room that can profoundly shape the outcome. Whether they remove 60, 80, or 100% of the tumor, it's never just a number. It's a life-changing effort to give our children their best chance. But beyond the operating room, for families like ours, surgery is an emotional milestone. It's the sleepless night before, it's the quiet prayers whispered in the hospital corridors, and it's the heart-stopping moment when we first see our child in recovery, fragile, surrounded by machines, but still fighting. Surgery is one of the few moments in this journey where something physical is taken away, and we hold on to hope that what's gone is enough. It marks a critical pause in the journey, a moment to catch our breath, to reevaluate, and to prepare for what comes next. It's a point where progress can be seen, not just measured in scans or numbers, but felt. It's the first time in a long while we dare to believe, maybe, just maybe, we're turning the tide. Yes, it's a medical milestone, but also a milestone of the heart, one that leaves lasting mark on every parent, every child, and every story like ours. I'm honored to welcome Dr. Michael LaQuaglia to our webinar today. Dr. LaQuaglia is the legendary pediatric surgeon at MSK, Memorial Sloan Kettering, with 38 years of experience in clinical practice, research, and training. He has done the impossible for so many children and their families. As Dr. Kushner mentioned in our last webinar, he attributes the cure of so many patients directly to Dr. LaQuaglia's expertise. Tumors that were once considered unresectable, getting them out made all the difference in the world. Dr. LaQuaglia, thank you so much for being with us today. We're truly privileged to have you here, and we're looking forward to your presentation.
It's my honor, and thank you for having me. May I share my screen now? Let's see.
Yes, please.
Is that visible?
Yes.
Good. Okay. So again, thank you very much for allowing me to speak to the Shear Foundation. I think that it has been an evolution over time in the surgical treatment of neuroblastoma. I don't have any disclosures. So this is, as was pointed out, this is from Edward Kiley, who also worked very hard in this field in England. And it shows you the major blood vessels in the abdomen here. You can see my arrow there. These are the vessels that go to the kidneys, to the intestines, to the lower part of the intestines, the colon, and the tumor tends to wrap around these structures, which has always made the surgery of neuroblastoma quite difficult, and has made surgeons sort of shy away from trying to do surgery for this. And if we look at these data, which go to 2004, the outcomes for the high-risk patients, the ones that have metastatic disease in the main, were not acceptable. They were below 50% in terms of survival. And so when I started at Sloan Kettering years ago, we worked on a number of aspects of this tumor, which included not only the surgery, but the chemotherapy, the antibody therapy, and the radiation. You can see that our survivals now, the protocol that we started with was the N4, which was completely unacceptable. And as we go through, we're now in the N9 or the N10. I'm not quite sure which. The survivals have increased. And this has been reported also in the literature, although this includes patients with both high risk and low risk tumor. And that's important to understand that there's a risk factor for neuroblastomas. But the scene is getting better. The outcomes are improving for neuroblastoma. So in the United States, it consists of 8 to 10% of all childhood cancers. It's got a prevalence of 1 case per 700 live births, and we think there's about 500 to 750 new cases in the United States, and that's an incidence of 8 to 9 per million per year. Neuroblastoma is the most common solid tumor in children apart from the brain tumors. Brain tumors are more common, but neuroblastoma is the most common solid tumor that's extracranial. I won't dwell on this, but it was described by Virchow, who just seemed to have described everything. Marchand was the first to notice that this was a nerve tumor and not a lymphosarcoma or something. Cameron Wright was a famous American who used silver staining, or rather, he described the characteristic appearance of neuroblastoma under the microscope, the rosettes, the right rosettes, and then Herxheimer did the neural staining with silver. So it was an evolution before it was even called neuroblastoma. These are just the pictures of those famous people from the past. And this is a Homer Wright rosette, which if you look at this, if I can get my thing to work here, you can see that if you think of a bouquet of flowers or a circle of flowers, and in the middle it's empty, that's the characteristic finding under the microscope for neuroblastoma. Of importance for surgeons is that the first description of removal, and it was a complete removal of a neurosurgeon, was done by a person by the name of Bartlett, that I could find anyway in the literature, in 1916. And this patient was alive and well in 1931. And of course, this was a low-risk neuroblastoma. It was a very fleshy tumor. It had neuroblastic elements, but it also had a lot of ganglioneuroma in it. We'll get into the fact that risk is so important in assessing neuroblastoma patients at diagnosis, and that treating high risk, intermediate risk, and low risk differs. Again, this patient was alive 15 years after surgery, and that was in 1916. I mentioned my other colleagues, we were talking with Einat, and I was talking about my other colleagues, but Dr. Chung, who had started at the same time as I did at Sloan Kettering, showed this important information, and that is that if you take the dose intensity of chemotherapy, what does that mean? It means the dose, the strength of the chemotherapy that you give over the time you give it. So it's intensity. And then you look at survival. As you got a higher intensity, you had a higher survival. So strong chemotherapy has been the byword for neuroblastoma since those times. So you can't use light chemotherapy that you might use for other types of tumors, but it has to be dose-intense chemotherapy. And of course, another colleague with us, Suzanne Walden, showed that radiation could help improve the local therapy, especially when the tumors were completely removed, but not microscopically completely removed, because that's almost an impossibility in most cases. So radiation is important. Finally, I would point out that since 1987, we've used antibody treatments, but Alice Yu in this children's oncology group published a report in the New England Journal that showed that antibody therapy, immunotherapy, was important as well in the survival from neuroblastoma. So now we have the combination of dose-intense chemotherapy. It can't be light chemotherapy. We have the ability to use radiation, although not a high dose of radiation. And we have the antibody as part of the armamentarium to fight against this disease. And so it allowed perhaps some unveiling of the effects of surgery. So just in terms of the diagnosis, many of you may know that this presents as an abdominal mass. Often grandma will be bathing the child and she'll feel this lump and she'll say, "What is this?" The children may have bone pain and therefore they're limping or they're not walking when they had been walking before. Anemia is caused by the bone marrow involvement, which we'll show, and that suppresses the cells that are making the red cells in the bone marrow. Opsomyoclonus, I'll get into it just a little bit in a minute, but it means a cross reaction between cells in the brain and cells in the tumor by the patient's own immune system. And it causes this neurologic syndrome called opsoclonus myoclonus. There can be hemorrhages that are seen, and weight loss and fever are very common with this disease. Children have no appetite. So opsoclonus is rapid eye movement, and myoclonus is uncontrolled jerky movements of the arms. It's associated with cerebellar ataxia, which means a loss of balance, inability to express words, vomiting, and intellectual deficits. And again, this just shows you this is the mechanism. We think that the reason why this happens, and that is the body is making antibodies against the neuroblastoma, and these antibodies actually are cross-reacting with normal brain antigens as well. And so this is sort of an autoimmune effect of the neuroblastoma. The workup is fairly straightforward. There's a history and a physical. These tumors are suspected from the child not walking, therefore possibly bony involvement. A mass is felt. There may be hemorrhages. I'll show you a picture of those. And so an ultrasound is usually the first thing that's done for any abdominal mass by any pediatrician. But then this is followed by a CAT scan, and usually that's done with contrast, so the blood vessels may be visualized. I showed you that picture of the blood vessels being involved in these tumors. The MIBG scan has replaced the bone scan nowadays. The MIBG is meta-iodylbenzyl guanidine, and it's a chemical that looks like tyrosine to the body. Tyrosine is used to make dopamine. So what you're giving is something that the body thinks is what it needs to make dopamine, and dopamine is involved in the neuroblastoma. These cells are from the sympathetic nervous system. They make what are called catecholamines, which are things that are related to epinephrine chemically. And the MIBG is taken up as a precursor and goes into the cells because thinks it's making these epinephrine precursors. And it stays in the cell and allows us to visualize the tumor. About 85% of neuroblastomas are MIBG positive. Some are not, and we use PET scan in that case. MRIs are used whenever there's spinal disease. I'll show you a picture of that in a sec. So there's a little baby that has we call them raccoon's eyes. You can see that there's the child looks like he may have been abused or hit, but this is an uncommon sight for child abuse. What it's caused by is the fact that the tumor has gone into the bones behind the eye and there's been some hemorrhaging, and the hemorrhaging has come out on the skin. This is another manifestation. This is a cutaneous metastasis of a neuroblastoma. It can show up in the skin like this. It can actually go into the skin. And this can be biopsied to make the diagnosis of neuroblastoma. This is usually associated with a special category of neuroblastoma called 4S, and usually is associated with a better prognosis. So this is what they look like when we see them. Not sure why it's a large mass in the abdomen. The structures over here, the whitish structures that so you can see the spine and back as that large white structure. And then in front of that are whitish structures that look like little squiggly lines. And that's really the celiac axis, or sorry, the superior mesenteric artery, and you can see the vena cava in front. So this is a typical appearance of a neuroblastoma that's already wrapping around the blood vessels in the body. This is an MRI scan, and it shows the arrow is pointing to the tumor extending from outside where the tumor starts and going through the little holes in the spinal canal that allow the nerves to exit the spinal canal to go to the rest of the body. Well, the tumor can grow through those little holes and infiltrate into the spinal area. And that circular thing in the middle that looks like a target right here is the spinal cord, and the black circle on the outside of it is the fluid around the spinal cord. So you can see that these MRIs give us information about the spinal area and the involvement of spinal structures, of the neural structures. This is the old bone scan. It shows you that you can have this disease in the abdomen, a large lymph node here. This is a large lymph node in the chest, if you see my arrow. And then this is the amount of disease that's in the skeleton caused by the tumor metastasizing from the left adrenal gland here to the rest of the skeletal area and to other areas of the body. So this is what you're confronted with. And this, for surgeons, is not considered the primary or the most amenable or easiest kind of presentation to work on if you're going to try to take out the tumor, because why should you try to take out this tumor here in the adrenal gland when you have all this metastatic disease? And this relates back to what I showed you about the chemotherapy, the immunotherapy, and the radiation therapy, that those things can work together. So we push everything together as a multidisciplinary treatment to try to take out the neuroblastoma part by part. This is an MIBG scan of that patient. It just shows you the extent of disease that you can see on an MIBG scan in neuroblastoma. This is a common presentation, but still in this day, we still cure many of these patients. This is the PET scan that's used sometimes when the neuroblastomas don't take up MIBG. In the 15% of cases or so they don't take up MIBG, we use PET scan, and you can see that there's a good resolution of the PET scan for soft tissue areas. It's harder to see on this MIBG as opposed to the PET scan. So the MIBG is good sometimes for soft tissue disease. On the other hand, the PET scans, because the brain has a lot of activity, the PET scans are glucose scans. It's glucose metabolism that you're looking at, that's sugar metabolism. The brain, of course, is very metabolic and therefore uses a lot of glucose. And so your brain scan on the PET scan is obscured by the brain uptake, and so you can't see this. So the MIBG is better for cranial metastases. And of course, nowadays, these are done are correlated with the CAT scan. This just shows you a large tumor in the pelvis. So you can see these are the beginning of the hip bones here and a large tumor. And it shows you the fact that these tumors can be anywhere from the head to really to the pelvis. This is an MRI in the pelvis, which can also show the tumor and give a little bit more anatomic definition. For instance, here's the tumor, but you can see the bladder quite clearly in front, so you know that it's away from the bladder. And this is a PET scan, which shows you if you combine it with the CAT scan, you can get good resolution of the tumor here. And what you're seeing in front is the glucose, the radioactive glucose coming out in the urine into the bladder, so you can see the bladder. So you can see areas that are normal and the areas that are abnormal in their relationship in 3 dimensions. The tumor, to do the diagnosis here, requires a biopsy. This might be a bone marrow biopsy or an open biopsy of the abdominal tumor. We try to use small incisions when we do this. We often plan the incision so that when we come back for the definitive removal, which we call a resection, we can go back through the same incision and not require another scar. So I was telling you about the risk, and this is really, I think, a very important concept. I have to go through it on a sort of a superficial basis, but it's a very important concept because you have to judge risk before you know what you can do to treat the patient. So the variables that often fit into risk status include the age. That is, if they're older than 18 months of age, and if you're 17 and a half months, it gets, you have to think about it a little bit more. A staging system, which has evolved over the years. The way it looks under the microscope, which is called the modified Shimada criteria or modified grade. And then biological variables, which are related to DNA or analysis of the chromosomes. For instance, an oncogene called MYC-N, and that's just the way the name. I think the person that identified this was in Michael Bishop's and Harold Varmus's lab in San Francisco, and his name was Manfred. And so MYC, the M in MYC, I believe, is from Manfred. Anyway, the MYC-N amplification has been shown to be important. The DNA index, the amount of extra DNA that's seen in the cells has been important. And then there are certain chromosomal abnormalities that are important, and they're combined together to form a risk system. So this just shows you where this is Wendy English's work and others, Sue Cohen, that showed that they took about 8,000 patients and they tried to understand where did the event-free survival, in other words, their survival, start to drop off by age. Because initially when we had first done this, people were saying 1 year of age, and it really drops off about here, which is at 18 months if you're able to write this down. So below 18 months, it's considered a favorable variable. Above 18 months, it's unfavorable. But remember, it all has to be taken in context of everything else. There are always a lot of moving parts. So the stage is related. Nowadays, the stage used to be very much related to surgery, but we try to get away from trying to stage patients based on surgery. In other words, the old way of doing it was if the tumor was completely removed, but with microscopic, if the tumor was completely removed with would be left gross disease, lumps you could see, or if it was metastatic. But that really doesn't help you when you're trying to assess a patient who's just diagnosed, because the act of removing the tumor, first of all, it's user dependent. Some people remove some tumors, other people don't remove those tumors. And you want to have something that's more ironclad that you can do at the time of diagnosis. So one of the concepts that was brought out was this concept of an image-defined risk factor. That is an IDRF, an image-defined risk factor. And then you could make a staging system based on this. What does this mean? Well, in neuroblastoma, I showed you some pictures of tumors that were going around the blood vessels. Here's a very valuable tool, a three-dimensional reconstruction. So this is just the blood vessels to the liver. You can see the heart here. Here's the left kidney. Here's the right kidney. Here's the tumor is in green. And you can see there's two arteries coming to the right kidney. And you can see another artery which is going to the gonads down below. And so you can take these X-rays and you can make a judgment as to whether or not the tumor is touching the blood vessel or just slightly indenting it, or less than 50% of its circumference is involved, or greater than 50%, or it's completely encasing it, or it's completely blocked the blood vessel. And so you can say they have these image-defined risk factors if they have findings on this side where my arrow is, whereas if they don't have them, if they have findings on this side. And this is just it's a fairly straightforward concept. Sometimes it's hard it requires a little bit of experience to apply it, but basically it's fairly straightforward. And most radiologists, most units that do pediatric radiology and image pediatric tumors can come up with these findings. And so this is just to show you a tumor this is the IVC is inferior vena cava, and this is the aorta, and this blue is the tumor. And so, it's got image-defined risk factors because there's complete vascular encasement. And here's another picture of that where there's blood vessel going right through the tumor, and the iliac arteries are involved here. And then for the neural system, there is as well. In other words, I showed you a picture of a tumor that was going into the spinal canal. Sometimes it can just bulge into the spinal canal, and that's not an image-defined risk factor. And sometimes it goes into the spinal canal, and that is an image-defined risk factor. So you look at the tumor, and here's a picture. This just shows you a real X-ray of that, where the tumor has come from outside and gone right inside here. And you can see the spinal cord is that little orange thing there, and the tumor is really pushing up on it. So this is then allows us to devise a staging system. L1 is a localized tumor that does not, and localized is important, but it does not involve vital structures by the image-defined risk factor criteria and confined to one body compartment. L2 is a local regional tumor that their lymph nodes regionally can be involved, and there are image-defined risk factors, and then distant metastases. And MS is this special category of patients younger than 18 months of age, and they can have metastases to the skin, the liver, or the bone marrow. It has to be less than 10%. And they occur in these babies. And this has a different criteria as described by Audrey Evans at the Children's Hospital of Philadelphia. And these patients have a tendency to do very well with neuroblastoma. So you can see that this status, if you take a large number of patients, you can stratify by this status, and you can see that it does work, that your outcomes are better for L1 versus L2. So it's a staging system. It tells you, what patients do worse, what patients do better, just as we saw with the age. This is the histopathology. This is what the pathologist looks at when he's under the microscope. And when they're looking at are these nuclei, and they're looking at whether the nuclei are kind of really compressed or they're breaking apart. And this is called karyorrhexis. And they give it a score of unfavorable or favorable histology. And you can see that that also affects survival, that unfavorable histology greater than 12 months, unfavorable histology less than 12 months, it does affect survival. So the histology is important in terms of the risk. And this just shows that in another picture of that, and showing that the favorable histology patients do better than the unfavorable histology patients. And then I talked about the MYC and oncogene. It's done by in situ hybridization now. You can see these are the gene amplified, the number. So everybody has two genes, one from mom and one from dad. But in neuroblastoma, if you're MYC and amplified, you can have hundreds of the MYC-N gene. And that has been associated with a bad outcome. And you can see from this New England Journal article from years ago that if you have NMYC amplification that is greater than 10 copies of the gene, you do worse than if you don't. And this is for all the different stages of the tumor. So there's a lot of moving parts in terms of risk. And the ploidy is just this DNA index, and you have a DNA index of 1 is worse, whereas if the DNA index is greater than 1, it's better. This usually means the cell is unstable and it's fairly easy to kill and doesn't have a longevity. And so you can take all this information and you can put it into risk groups. And these risk groups over here have an event-free survival that goes down as you go from very low to high risk. And so high risk is less than 50% event-free survival. Intermediate is 50 to 75%, et cetera. So risk, again, is important. What is the risk of this tumor to the patient? And this just shows you a tree by Tom Montclair, who was a colleague of mine, a pediatric surgeon from Norway, who takes the staging system here. That's the trunk. And as you go out, you can apply the MYC-N or some of the genetic abnormalities and so forth, the ploidy, the age, and you can build this tree, this nomogram. And if your circle is green, that's a better outcome. If your circle is red, that's a higher risk tumor. So you see an L2 tumor that's MYC amplified becomes high risk, even though it's L2. The point is that we are now able to look at a lot of this information, and a big part of what the cooperative groups do is look at this information to tell us how risky the tumor is to the child, and therefore what we have to do to try to cure it. So one of the things about neuroblastoma surgery, I showed you Dr. Chung's work and Glenn Heller's work with the chemotherapy, is if you give chemotherapy, you can start with a big tumor like this and shrink it. So that's another thing that helped us in terms of how we could use surgery to work with the other modalities. We could realize, and we actually published this, and here's that publication work that we did that shows that after cycles of chemotherapy, the tumor volume falls. But not only the tumor volume, but the tumor vascularity, the number of cells, et cetera. So we give chemotherapy for many tumors prior to surgery. Now, some tumors don't respond and it gets a little complicated, but in this particular sequence, I would keep in mind that we're dealing mostly with high-risk tumors at this point. There are some intermediate risk tumors that don't respond to chemotherapy, and that becomes a very complex subject. But for the purposes of this discussion in the next few slides, we're talking about high-risk tumors. So high-risk tumors respond to chemotherapy. They start at this volume, they fall like a logarithm if you were to do the math on this, like first order kinetics and essentially. And so after about 3 cycles, you have a tumor that's not going to it gets on this asymptote and it doesn't get any smaller and it's less vascular. And so you should do the surgery after 3 cycles of chemotherapy. Sometimes they'll do it after 4 or 5 just for efficiency in terms of getting the protocol. We do it after 3 at Sloan Kettering. The other concept that one has to realize about neuroblastoma, it's not like colon cancer or melanoma where you want to take it out and have no cells on the margin. Remember, I showed you many pictures and x-rays and pictures of tumors that were wrapped around blood vessels and nerves, the spinal cord. These are things we can't remove or shouldn't, don't normally want to remove, and would make the morbidity of the surgery much worse. And so we're taking out what we can see and what we can feel down to what we feel is normal tissue. So the margin is always positive. That is, there might be microscopic cells right on the surface of the tumor you're removing. We call it an R1 resection, but so this is an important concept, I think. Now, most of these tumors that we deal with that are high-risk neuroblastomas are arising from the adrenal gland or the sympathetic system in the upper abdomen. So they're up in the upper abdomen, 75% are in that area. And we use this thoraco-abdominal approach with the baby on its side, almost like we're going in the chest, so that we can get to these blood vessels. So again, you see a picture, a CAT scan of the tumor. It's going around the aorta here. You see this is tumor. That's the aorta. And this is the celiac axis, which is the artery to the spleen goes this way. And you can just see the artery to the liver coming up this way. So there's a lot of encasement of these blood vessels. So we want to give chemotherapy and try to shrink them so that we can do this kind of surgery where we dissect out all the blood vessels down to the muscles. You can see this looks like the superior mesenteric artery here, the celiac axis, the vena cava on this side, and the aorta going down. This is the artery. This is the kidney over here, and this is the artery to the kidney. So we're peeling that tumor out. This is a picture of that celiac axis, the artery to the liver and the spleen. And this is the superior mesenteric artery. This is the artery that goes to all the large intestine and about half of the colon. A very important artery to preserve. But the tumor can actually be wrapped around both of those structures. And this is just another patient. This is the left renal vein, the vein to the left kidney, and then the artery to the left kidney here, the aorta, the superior mesenteric artery, and the celiac axis. And just another picture of the same thing. So what we want to do is we want to take that tumor that you saw in that CAT scan and make it look like this. See all the blood vessels, see all the other structures, so that we know that we've cleared it completely. But remember, we're peeling it off. We're not taking out the superior mesenteric artery or the celiac axis or anything else. We're just peeling off those structures for a lot of reasons that I can't get into. It would just be too morbid. One of the reasons why we use this little chest incision in the lower chest is because the upper abdomen, where these tumors usually occur, is under the diaphragm. So if you go in front, you have to reach up under here to try to get to it. And this is from the Visible Human Project from our NIH, that where they took cadavers and they put together what would be a, what would a diaphragm look like anatomically in a human from CAT scans, and they reconstructed this diaphragm this way. This incision that we make was first described by a Frenchman called Lanelonge, who was a contemporary of Pasteur, who was actually an orthopedic surgeon. He actually never did the incision, but described it. And the people that really that I read about and learned it from, including my mentor, Dr. Hendren at the Boston Children's Hospital, but it was actually Dr. DeBakey and his colleagues down in Texas who often use this to get to the aorta, to get to these big aortic aneurysms. And so this was a perfect incision because what we're trying to do is get to the aorta as well, but our motivation is to remove the tumor, not to fix the aneurysm. This is a patient that had a MICAN amplified tumor. He's already received 5 rounds of chemotherapy. If you look back here, this lighter area is his aorta with the celiac axis. And then this is the superior mesenteric artery. You can see the aorta and the superior mesenteric artery. And all of this is tumor. All of this is tumor. This is a picture that wasn't exactly that patient, but this is the kind of approach that we use where the patient's on their side. You see there's an incredible amount of padding. This is for thermal regulation. In other words, this is a warming blanket that keeps the baby warm. We keep plastic on the head to keep the baby warm. You can see the padding under here. This is all silicone sheeting and so forth. And so this is that patient I showed you those x-rays, the large tumor that hadn't responded very well as we wanted to chemotherapy. And you can see this is the incision that we make. We go through the ribs there. We're putting in a retractor to hold the ribs apart. And now we're starting to move the stomach and the spleen to the left side. And now you can see we're down on the tumor. We use a lot of neurosurgical instruments. The brain surgeons use these fine instruments, which we've adapted to this to try to get in there. But you can see the aorta beating here, and we're peeling the tumor away from the aorta very slowly and carefully to avoid bleeding, of course, which would be a major problem. And so now we're working again with neurosurgical instruments to peel the tumor here. And you can see the kidneys here. This is an argon beam coagulator, which we use to help stop the bleeding. Again, that's a Penfield dissector for dissection. And we continue to mobilize the tumor. You can see that this is the big pulses in the aorta and this superior. Now, this is the end. I've jumped to the end, and you can see this is the celiac axis, superior mesenteric artery, kidney artery to the left kidney. The vein is below. You can see the vena cava down here, and the vena cava, the vein coming to the kidney. So this is what we want to do. And this is the result. These are just clips around the aorta, but basically we were able to clear out that whole tumor by using those techniques and that approach and so forth. So we like the thoracoabdominal incision. I teach it to all my fellows, and many of them are now using it where they've gone. They give you good exposure. They allow for dissection of the visceral arteries and salvage of the kidney, which we also think we like to do if we can. And we've had no cases of mesenteric compromise. And I think it improves both the ability to do the surgery and the safety of the surgery. Other tumors can be in the chest, and for this we use the usual thoracotomy incisions. Some tumors are very vexatious. They're up in the upper part of the chest where the chest and the neck come together. We call that the cervical thoracic junction. And unfortunately, this is the collarbone. The collarbone is taken away here, but you can see all these blood vessels and nerves are there. You can see that the red are arteries and the blue are veins and the yellow are nerves, and the nerve to the arm, the nerve to the vocal cord, everything is up there. And so for this, we use this kind of an incision where we go across and down and we open the sternum and we come across the chest. And this allows us to open the area up and actually see this, get a really good view into that. We did one last Thursday, actually. And so we can control the carotid and subclavian arteries, and we can find the nerves, especially the nerve that goes to the vocal cord and the one that goes to the diaphragm. and the nerves to the arm and peel these tumors out from there. You can see these nerves are here, these yellow things, and so they're in the way. And this is just a dissection of that area, shows you the nerves dissected out and the carotid artery going to the head and the subclavian artery going up. This is the subclavian, this is the carotid, the arch of the aorta, and we've peeled this tumor from around this whole area. And then for the pelvic tumors, we use lower abdominal incisions and go in the pelvis. One of the problems that you can have, as you might imagine, when you're dealing with blood vessels like this, is that the artery may not be of good quality. In other words, if the tumor has wrapped around the artery, or especially if they've given radiation at an outside institution, the artery may be weakened. This is one case where the artery started to fall apart and we had to put a little graft in. And this is now 10 years after that graft. We did an MRI that shows that the graft is open and the flow to the arteries to the leg is good. And we measured the length of the child's extremities, which we can do now, and they were normal. So sometimes we have to do vascular surgery. It's very uncommon, but you have to be able to do it and have a team that can do it with you. This is another kid that had a tumor. This is all tumor here. This is down toward the pelvis area, the lumbar area, and the aorta's here. And they gave this kid a large amount of radiation to this area. And this is the same child. And the aorta's here, came from another institution. And again, you can see that there's tumor and a lot of radiation has been delivered to this area. And it really the artery to the right leg started to really um, um, become unstable. And because of that, we put a graft in, which has worked out pretty well. So why do we do this? Why do we, operate on these big tumors? There's a tumor. All this is tumor. This is the aorta, the large artery of the body. This is the big artery that goes below. These are the kidneys. Why are we putting these kids through this kind of surgery? Well, as I say, we work together, but if we look at our data, we work together with our oncologists. If we look at our data, we did a paper where we looked at the patients that had tumor wrapped around the different arteries. So we divided it into the renal arteries, which means the arteries to the kidney, the celiac axis, that's just the name of it, celiac axis, which is the artery to the liver and the spleen, and the superior mesenteric artery, or SMA, which is the artery to the intestines. And then we looked at all the combinations and permutations, and we listed those patients, and we put down in blue if they had a complete resection, and an incomplete resection is in green. And you can see that given all these permutations and combinations, we were able to perform this kind of resection in most of the patients. At that time, we had a rate of removing all the tumor, and I'm talking about the tumors that I showed you before, these big, heavy tumors that involve all the blood vessels, at 94%. It's probably better than that now as we've gotten more experience doing this. So what were the complications? I mean, how much does this hurt the child to do this? And if we look at this, most of the complications are grade 1, which are usually medications or, in other words, complications that are not requiring in the hospital and not requiring intravenous. They might be a C. diff or something postoperatively that requires an antibiotic. That's the biggest category, 75%. The second biggest category are grade 3 complications, and these are in the main complications to the urine tube that runs from the kidney to the bladder, because these tumors often involve this area or involve the blood vessels around those urine tubes, the ureters. And so you can have some scarring of these areas. And these are treated by an operation which places a stent and then some kind of a repair. This is sort of inevitable when you take out these tumors and also after the radiation, because the blood supply sometimes to these urine tubes is reduced. But happily, we've developed techniques to just repair them later on and so that they can be dealt with. Sometimes they'll get better by themselves by simply placing a tube in the bladder, going with a scope in the bladder and putting an internal tube in, which we call a stent. Sometimes we actually go in and actually fix them. And then we looked at how many kidneys do we lose. And in that whole group of patients, the resection rate was 4.3, or the nephrectomy rate, the removal of the kidney was 4.3%. But if we look at those patients and looked at the kidneys that were destroyed before we did the surgery, in other words, the tumor had destroyed the kidney, then it's really only about 2.9%. So about 3% of kidneys are removed. So what does it do for the tumor? Well, if you review the literature, which I did a long time ago, the literature is not very clear. But if you put all these cases together, and these are the authors of many of those older papers, and you try to do a meta-analysis, you find that the risk is lowered by 30%, 33% if you are able to more completely remove the tumor, the risk of death from the tumor. And if you look at the local control, that is, does the tumor come back where it started in the abdomen in the main? Then the risk is actually even better, that you greatly affect the chances that the tumor will not come back. In other words, you lower the risk of the tumor coming back in the area where it started, where you operated, which is of importance. The cure is the local control versus plus the distant control. So the local control we're greatly affecting, which we would expect, since that's what we're dealing with. That's what we're actually operating on, is the local tumor. So we're able to take this into the Children's Oncology Group, and this is a paper that I wrote from the COG 3973 study where we had prospective data. And what this shows is if we had a greater than 90% resection, the event-free survival was better, and that was significant. And importantly, if we had a greater than 90% resection, the local recurrence rate was very low, it was less than 10%, whereas it was greater than 25% if you didn't. Local progression of disease. In other words, the tumor coming back where it had started. So obviously, there's a correlation with local control. When we look at the complications from this kind of surgery, we find that the rates of kidney injury, vascular injury, bowel obstruction, pulmonary complications, wound complications like infections or the wound opening up, and the volume of blood loss, the amount of blood loss, are not statistically different for a better resection versus a less extensive resection. And finally, to confirm this, the SciPen group, which is the international European, in the main, it's a European group, had more than 1,500 patients. And you can see the red is what they call the complete resection. And you can see that the event-free survival, the overall survival was better, and the local control was better. The local recurrence rate was much lower both in the pre-immunotherapy group and the post-immunotherapy group. So they confirmed what we found in the Children's Oncology Group, and that is that the surgery does play a role, combined with everything else, to improve the outcome, both local control and actually overall survival. So I'm going to jump now. I'm just going to talk quickly about low and intermediate risk neuroblastoma. So this is a kid who had this tumor, never responded to chemotherapy over 1 year at outside institutions, and they were going to do a bone marrow transplant on him with this. But because we used the techniques that I spoke to you about, we're able to remove this, and he never received any further chemotherapy. He's actually married now. This is another tumor like that, and these are other tumors that either had a little bit of chemotherapy or no chemotherapy and were removed. This gets a little complicated, and I don't want to confuse you with some of these, but for these tumors, these are tumors that can be removed sometimes, and either very little chemotherapy is given or no chemotherapy is given. And we can see that their event-free or progression-free survival was 88%. This starts at 80, just so you see that. So it's 88% progression-free survival, which is very good, and the overall survival was 94%. The two patients who had mortality in this series were stage 4 patients who we didn't identify initially as stage 4, and they were treated as intermediate risk. And that gets into a very complicated subject that I don't think we have time today, and probably I'm not the best person to describe it. But I think what I'm saying is that these patients receive a minimum of chemotherapy and can be cured by the chemotherapy and the surgery. There are important concepts now in these intermediate risk tumors. In other words, do you have to take out the tumor at all? Do you have to take out only part of the tumor? And these are questions that are being asked by the cooperative group. At present, at Sloan Kettering, we tend to, if we think we can remove it safely, we do take it out. The other category is this 4S. So we went through the intermediate risk, which are the L1s and the L2s. We went through the high risk, which is the M. 4S is the MS, and these are metastatic at diagnosis, but they're usually under 6 months of age. They often have liver disease, liver metastases. The bone marrow involvement can be present, but is less than 10%. They can have a cortical bone involvement. If they have a positive bone scan, they're not 4S. These are the ones that will go away by themselves sometimes, but they may require chemotherapy if the liver is expanding. So usually, if the child is young, if it's under 3 months of age, the liver metastases may grow and not controlled and not be controlled. And this may cause too much pressure in the abdomen, reducing the blood flow to the normal organs, to the liver and to the kidneys. And so they may require chemotherapy and sometimes radiation therapy. Of importance in this group, this 4S group, or the now 4M group, is that you don't have to take out the primary tumor, which is usually an adrenal tumor. So if you look at this, you can see that if they were less than 90 days of age at diagnosis, less than 3 months, their outcome's a little worse. And that's because there's so little that when the liver expands, it causes a lot of pressure in the abdomen. So these patients will get chemotherapy. Surgery plays pretty much no role except for a biopsy in 4M patients. And this just shows that if you have to do an intervention, that's associated with a worse prognosis. And as I said, many of these patients, and these were described by many, many years ago from Yale, these were the first tumors that you could see would undergo spontaneous resolution, which can occur in neuroblastoma. It goes away by itself. And so if you look at the literature, there was one relapse in 47% of patients not undergoing removal of their tumor, of their primary tumor, which is an adrenal tumor. So it starts in the adrenal, but the real problem is the tumor goes in the liver and makes the liver huge. So these are metastases, not the primary tumor. And then in 50 patients, there were 2 relapses in 50 patients that underwent primary resection. So primary resection is not essential. Unfortunately, it can be very dangerous. They have big liver tumors, and the primary tumor, which is in the adrenal gland, which is just above the kidney, is behind the liver itself. And so there could be a lot of problems with the liver or bleeding from the liver as you do this. And one of the things you should know about, and this is Jed Nuchturn's work from the COG, are the pre and neonatal adrenal neuroblastomas, the ones that are diagnosed by prenatal ultrasound or just as in the newborn period. And so they developed ultrasound criteria for the volume of these tumors that allowed the patients to go on a protocol which was observational. They just got serial ultrasounds and no intervention. So they started with 87 patients, and then 4 patients, the parents wanted to remove the tumor out, and they were removed. So it was 83 that were eventually observed. You can see this is a prenatal ultrasound showing this tumor above the kidney here. And then subsequently 3 were removed at patient request. Only 2 of those were neuroblastoma. One was called an adrenal hemorrhage, which can occur in these little babies. And then 2 underwent resection because they triggered the protocol, which was measuring the volume. The volume got too high. And one was a stage 1 tumor and one was a stage 4S. But if you look at the data, the event-free survival for this whole group was 97.7%. And for any malignancy other than neuroblastoma was 95%. And the overall survival was 100%. And in this group, you can see that this is the event-free survival and the overall survival, just the curves. And then if you look at observation only, the resection-free survival, it shows that 80% of the patients had no surgery. So this is actually very important because it means that, and it goes along with this thing I've been saying about risk, that if you identify these newborns and you have ultrasound and they fulfill the criteria, you can observe them and they can completely avoid surgery. And this went out for a number of years. So I think that that's also an important finding in neuroblastoma. And again, it means that we work closely with our colleagues. So neuroblastoma is heterogeneous, risk is essential. Therapy continues to involve what we're trying to reduce therapy in the lower risk patients and increase the intensity of therapy and use new therapies in the high risk patients. And I think the surgeon, through my career, but into the future that's foreseeable that I can see as my career starts to go away, is that it will still require the input from the surgeons. Thank you a lot for allowing me to show this data.
Thank you. Let's take a few questions on the Q&A.
See participants. Let me just put this up like this. Chat Q&A. There's like 8. Okay, so ganglioneuroblastoma, you say, is likely to lead to a more favorite outcome. Is this still the case when the tumor has metastasized at the time of child? In this case, the patient was 5 years old. No. Okay, so there are nodular neuroblastomas that are favorable from a histology standpoint. I'm not typing the answer, right? I'm speaking the answer. Not right? Yeah. So I think that you have to take all the variables together. So there might be some variables that are one and other variables that are another, but you sort of have to take the overall presentation. So I don't know what the risk for this particular patient is, but ganglioneuroblastoma is not the same as nodular neuroblastoma. And so I think that ganglioneuroblastoma we tend to treat as if it were neuroblastoma. The 5 years of age, of course, would be a higher risk category than a lower risk. But I don't want to, without seeing the scans and looking at the other data, including the, cytogenetics and so forth, it'd be hard to tell what the risk is. If a tumor is operated on too early or before chemotherapy, for example, on attempt to remove during biopsy, what are the risks? So we know that the risks are higher and that the chances of completely removing it are lower. Could there be a chance of the tumor being too soft and breaking off? So yes, I think that when you operate on these tumors, if they're, especially the high-risk tumors, if they haven't received chemotherapy, the tumor doesn't form that fibrous capsule around it, and so the tumor can break up. Now, the thing about neuroblastoma is it doesn't usually implant like colon cancer would. It's not, so if it breaks apart, you remove the pieces and so forth, it doesn't like grow in the peritoneal cavity and so forth. On the other hand, we do emphasize that if it's a high-risk tumor, you just want to get the biopsy. And the biopsy could be a bone marrow test. If you do a good bone marrow and you have the cells and you have a positive MIBG scan, then you can pretty much make the diagnosis to give chemo and give chemotherapy at that point. So we do emphasize for many of these tumors to give the chemotherapy first before trying to do a resection. Okay, and then Debbie is saying, what are your thoughts about surgery in the area where the veins are behind the pancreas? I seem reluctant to try. There's currently a small amount of new disease. My daughter went section on her pancreas in October of last year and lost half of her pancreas and spleen. This will be her second relapse. Well, this is a very I actually have seen cases like this, and we do operate on them. But again, well, number one, I should state that I'm not giving medical advice here, okay? That I can't give medical advice, nor should you take it. The only way for me to give medical advice is for me to see the patient, review all the scans, and see the patient with my colleagues from neuroblastoma, and then present it to our group and so forth. So I can't really tell you what the right thing to do. I think that it sounds like there's been a lot of surgery, but we have had patients who've had a lot of surgery and we have gone in and removed tumors. This just requires, again, this is getting a second opinion at a place that has a lot of experience with this. Will surgery clips for lymph nodes be left in the body forever? And yes, and any long-term side effects from, I have them in me, so I've had clips put in during surgery. So I've had 5 operations. I'm not putting people through anything I wouldn't do myself. So, and I have had no long-term effects from it, except my golf game is not very good. And transient ischemic attacks, I've never heard of transient ischemic attacks from surgical clips. So I don't know anything about that. When you remove a large paraspinal tumor that hasn't got into the spine, it's very close to it and takes up a lot of space, do you consider the impact on the spine with the, do you prop up the spine? So I think what this parent is getting at is the fact that these large tumors in the chest put pressure on the vertebral bodies. And remember, these are growing structures, right? That's the one problem, one of the problems with children, with operating on children or with children that get tumors is that they're growing. And so what we see is there's an effect of the tumor, perhaps because it's drawing away blood vessels, perhaps our blood supply, perhaps because of pressure effects, perhaps because of all these things, that there can be some curvature of the spine, what's called scoliosis. The removing the tumor doesn't do anything for that. It won't, doesn't make the scoliosis better, I should say. It possibly could make the scoliosis worse over time. We don't do anything at that time. The treatment of that is best done. And what we normally do is have them followed by our pediatric spine orthopedic surgeons who are experienced with scoliosis. And the treatment might be a spinal procedure at some point, but usually when the child is older. We wouldn't do anything at the time of removing the tumor, nor have I seen any major immediate effects of removing the tumor. We, of course, worry about when we operate in the paraspinal area, the blood vessels to the spinal cord. And so not often, we always do this with neural monitoring. We have the neurologist and the neurophysiologist in the operating room. And when the child is asleep, they put a lot of little needles in and we can measure the impulses in the nerves and the muscles. And when we divide blood vessels, we usually pinch them first to see if there's any change in that monitoring, the neural monitoring. So you can cause spinal cord injuries with surgery in those areas. We use neural monitoring. Some people do angiograms. We think that's pretty invasive, but you could do an MRI angiogram, for instance. I'm not sure it helps. I think what you do is you pinch the blood vessels as you go along and see if any are cause a loss of the evoked potentials that they see in the neural monitoring. And the neurologist will tell that during the operation. They're right in there in the operating room. They'll say something. I have in one case pinched the blood vessel and the motor to the legs went away. And I let go of it and it came back. And I did it 2 more times just to make sure. And then I left tumor around that artery so as not to cause paralysis. And this is in a patient with intermediate risk tumor who did very well after that uh, because it was intermediate risk biology. So it wasn't going to get bigger and grow. It was just a little bit of tumor in the artery. That's how we approach it.
Maybe we
Um,
can take one
yeah,
more question just to
okay,
be respectful for everyone's time.
sure. So there's in, oh, thank you. Thank you. Yeah, well, thank you for having me. Excited listener from Heidelberg. So the person that described McN is, I think, lives in Heidelberg. Are there any long-term studies on children that have these kind of extensive abdominal surgeries at an early age and their risk for extensive adhesions, et cetera, et cetera? So there are, and Dr. Weldon has published from there's a extensive late effects group that is out of St. Jude Children's Hospital in Memphis, Tennessee, in the United States, and they have a lot of data. And they have published an increased risk of adhesions later on. We have seen adhesions after surgery in our own practice and so forth. I can tell you though that we have many, many patients. When I first came to Sloan Kettering after I was trained in Boston, the survival from high-risk neuroblastoma was almost zero. It was very difficult. And I can tell you that as time has gone on, and despite everything that's been done, and not only with surgery, but the radiation, there are complications related to adhesions and so forth. But each year or every couple of years, we have a reunion of patients that we've taken care of. We have so many patients that are getting married and so forth. An interesting thing happened to me recently. My niece, who is in her 20s, is a nurse practitioner in Philadelphia, and she was taking care of a high-risk pregnancy in Philadelphia, and her surname is my surname. She's married, but she uses her family surname, her premarital surname. And the woman she was taking care of was a young woman having a baby, looked at her surname and said, "Do you know me? Do you know Doctor?" And she said, I'm his niece." And she had been a neuroblastoma patient that I'd operated on like 20 years ago or 25 years ago or something like that. She was having a high-risk pregnancy, but she was having a kid. So it is, you do have late effects, and I think some of it is associated with the surgery. The radiation doesn't help, and the chemotherapy and the treatments, but I think we're having a lot of long-term survivors who seem to be having kids, getting married, getting PhDs, getting graduating from law schools and so forth and so on. So I think it's been worth it.
Thank you so much, Dr. LaQuaglia, for your fascinating presentation. We're deeply grateful for your time, for your wisdom and incredible knowledge you've shared with us today. Our next webinar will take place on June 5th, featuring Dr. Alicia Waldman, who will speak about pain management, especially during immunotherapy as side effects that we all know too well, and also about palliative care, which is not always what people think it is. You don't want to miss it, so please register. And thank you for your time.